Hi, I'm Dr. Kim Thornton. How are you? I'm from Boston IVF and wanted to welcome you to an evening of questions and answers. And hopefully, over the course of the next hour that we're going to spend together, I'll be able to answer many of the questions that you have in our audience. Um, I am a reproductive endocrinologist. I've been in practice now oh gosh, since 1991, but at Boston IVF since 1998. And currently have two offices. I see patients in our main office, which is the Waltham Center. And then I also see patients in our Worcester Center, which is at 100 MLK Boulevard, Suite 300 in Worcester, Mass. Um, I see we've been joined by a few people, so welcome and hello. Uh, what I thought maybe we should start off with, if you guys don't have any particular questions, is, what is infertility and when should you see a reproductive endocrinologist to start your evaluation for fertility? And basically, by definition, infertility is the inability to conceive after 1 year, if you are under the ages of 35, and if you're over the age of 35, then certainly we would welcome seeing you sooner. And typically, we like to wait at least 6 months of trying. Certainly, if you have other reasons to think that you need to be seen sooner, so for instance, for women, if you're not ovulating regularly, that would be a reason to come in sooner than that 6 months or 1 year. Because there may be things that we can do to be of assistance that will really enhance your chances of conceiving during that 1 year time period. So one of the questions that I see that's just coming up is, in terms of treatment, people are asking a few questions about IVF. So IVF is one of the more advanced treatments that we offer. And IVF involves stimulating the ovaries so that we can retrieve, hopefully, multiple eggs. And one of the things that patients always ask is, what's the ideal number of eggs that we would like to retrieve? And I don't know if there's really an ideal, just because the number of eggs that I might expect from someone who is, let's say, 30 years of age is going to be very different from what I would expect in a 40-year-old. So in general, for women who are less, I would say 35 or less, somewhere between 10 to 15 eggs would be ideal. And certainly if we can get more, that would, potentially be better. The more embryos that we have, or the more eggs that we have, typically the more mature eggs we will have, and therefore, we'll have better fertilization rates and better embryo development. But I think the one thing you have to remember is what we're really looking for is quality eggs and quality embryos, because those are the embryos that ultimately implant. Somebody asked the question about, is it preferred to have a fresh or a frozen embryo transfer? And, we have looked at our data with regards to our fresh embryo transfer success rates and frozen embryo success rates. And in both instances, pregnancy rates are, quite good. Again, stratified for patients based on their age. In most individuals who are not doing extra diagnostic testing on their embryos, we would initially plan on a fresh transfer. And the reasons that we might not do a fresh transfer were if you were having symptoms of ovarian overstimulation, or what we call the ovarian hyperstimulation syndrome. If you had a marked elevation in your serum progesterone prior to your retrieval, or if we had retrieved too many eggs and again we're worried about hyperstimulation, then we might elect to freeze all of the embryos. Otherwise, we would probably proceed with a fresh transfer. And then our frozen embryo transfer success rates are likewise quite good. And for those patients, that I've already mentioned that are either at risk for hyperstim or have the elevation in progesterone, then frozen embryo transfers are probably the way to go. We also do frozen embryo transfers for all of our patients who have either done pre-implantation genetic testing, so they've actually done genetic testing on their embryos, or for patients coming back for embryo transfers where they've either not conceived with their first transfer, or if they've had a baby and they have embryos frozen, they come back at a later date to transfer those embryos. Another question, what's the preferred grading for an embryo to transfer? There are a number of grading systems that are used. Most of our embryo transfers are done with day 5 embryos. And we grade embryos based on the stage of embryo development once they've reached the blastocyst stage. And blasts can be graded from stage 1 through stage 6. And really that number reflects the size of the blastocyst as it grows during that time period. And then we can grade both the inner cell mass, which is what becomes the fetus, and can grade the trophectoderm, which is placenta. And based on the size and the number of cells, those cells are given a grade A, B, or C. Certainly our best quality embryos, those embryos that we would prefer to transfer and are also of the quality to biopsy if we're doing genetic testing, or freeze, are those embryos that are generally stage 3 or above and grade A or B. And so those are the embryos that we prefer. That does not mean, however, that an embryo that has a C grade would not implant. What we found, however, is it doesn't survive the freezing and thawing process very well. And so we don't typically freeze those embryos. So another question, what are the signs, or I'm sorry, let me answer this one first. What would you recommend after testing 2 tested good embryos, if you will, transfers fail, and 1 day 5 transfer fails? I think it depends on the quality of the embryos. So, again, it's hard to be specific to answer that question specifically. If the embryos are day 3 embryos, we like them to be somewhere between 6 and 8 cells, and preferably grade A and grade B embryos. Those are embryos that are not very, very fragmented. And if they're blastocysts, then again, embryos on day 5 should be anywhere between stage 1 and 6, but typically we're seeing embryos that are stage 3 or 4, thereabouts. If you've not had embryos that have implanted, then you can make the decision to do genetic testing, because oftentimes embryos that don't implant have genetic abnormalities, and that's the reason for the failed implantation. And I'd probably start there. And then you want to make sure that the endometrium is developed, there are no structural abnormalities, and so you may want to have further evaluation of the uterine cavity. Other questions. So, what are the signs that you're not ovulating regularly when you have regular menstrual cycles? I think typically women who have regular menstrual cycles, and that means that they get a menstrual period every 28 days or every 30 days or even every 35 days, most likely they're probably ovulating. They're just not detecting the LH surge using those ovulation predictor kits. In general, ovulation occurs about 14 days prior to a menstrual cycle. So you need to, one, make sure that you're testing appropriately, and then sometimes the kit is not as sensitive or not as sensitive as we would like. Other ways that you can assess whether ovulation is occurring is monitor that ovulation with serum, or monitor the cycle rather, with serum blood tests so that you can check for the LH surge, and ultrasounds to actually look to see if an ovarian follicle develops. And 9 times out of 10, you're going to actually are ovulating. It was just you were missing the LH surge. Um, in terms of best ways to help someone ovulate, so in women who are not ovulating, after we've done a thorough evaluation, oftentimes we will start with medications such as Letrozole, which is an aromatase inhibitor, and that acts to stop the conversion of androgens, which are produced by the ovary, to estrogen. And that in turn makes your pituitary and sense that there's not a lot of estrogen around, and its response is to increase its synthesis and secretion of follicle stimulating hormone, which then can stimulate the ovary. Clomid is another medication that we use. It acts differently in that it's an estrogen receptor blocker, or blocks the estrogen receptor, and it does that at the level of the pituitary and also higher centers up in your brain. And ultimately, the pituitary produces more FSH and again stimulates the ovary to respond and hopefully ovulate. The ovary by giving follicle stimulating hormone by injection. And that typically causes multiple follicles to develop. And again, with monitoring, we can then induce ovulation by triggering the LH, a surrogate LH surge, if you will, with HCG, and that will cause ovulation to occur as well. We typically, if we're managing couples in the office, we'll start with the oral medications. And we do that because one, they're effective, and two, the multiple pregnancy rate associated with those medications is about 5%, which we think is still an acceptable multiple pregnancy risk. When we go to the injectable gonadotropins, very oftentimes women will over-respond and produce too many follicles, and that gives you too great of a risk of multiple pregnancy. So we don't do that as often anymore. We used to years ago. Question from Nicole: what is the success rate with IVF and ICSI for women over the age of 40? So in general, IVF success rates, or let me just step back a bit. In general, fertility rates decline in women as they get older. And so, in couples who are just not even undergoing fertility treatment at all, your best fertility rates are in women who are in their early 30s, and then there's a progressive decline. IVF will enhance the chances of success at each age range, but you will still see a decline in success rates. So, for instance, in someone who is less than 35, we would expect pregnancy rates that are somewhere between 35 and 40% if you're transferring one embryo. By the time you get to the age of 40, expect success rates about 20 to 25% if you're transferring two embryos, and if you're only transferring one embryo, it's going to be a little bit less than that. And that's presuming that the embryos are not genetically tested. If we do genetic testing of embryos, so that's the pre-implantation screening for or testing for aneuploidy, and that's where we're testing for the numerical chromosomal abnormalities such as trisomy 13 or trisomy 21, then we can identify embryos that are either not going to implant or that would implant and miscarry and not transfer those. In that case, when we're transferring embryos back into a uterus, by doing the genetic testing, you somewhat equalize implantation rates so that the likelihood of an individual embryo implanting that's been genetically testing and is chromosomally normal is about 60%. So for women as they get older, that's identify the chromosomally normal embryos and improve your overall likelihood of pregnancy per embryo transfer. So questions regarding the utilization of frozen sperm from either a known or an anonymous donor. In general, if donors from a anonymous donor sperm bank, then the donor banks typically would guarantee a certain yield of sperm, motile sperm per each vial of sperm that we thaw. With known donors, ideally you'd like to select a known donor that has a completely normal sperm concentration, which in most labs is somewhere between 15 to 20 million sperm per milliliter, and normal sperm motility, which should be greater than 40 to 50% depending on the lab, so that when those samples are frozen, and they're usually divided into 2 or 3 aliquots, when they're frozen, they should yield ideally somewhere between at least about 5 million total motile sperm after sperm thaw. And that's going to, based on many studies, yield adequate pregnancy rates. Certainly, we will see pregnancy rates with total motile sperm yields as low as 1 million motile sperm in the thawed sample, but ideally we'd like somewhere around 5 million or more. Question about what can you do to make better eggs and more eggs? So that's a little bit of a tricky question. Certainly for when we evaluate ovarian reserve, we're looking to really get an assessment of what we think the potential is for an individual to, they're going to respond to medications, and how a reasonable number of eggs. And if you remember from when I mentioned earlier this evening, the number of eggs that an individual is going to produce is going to vary with age. So in a woman with a normal, or what I would consider to be normal ovarian reserve, if we stimulate with kind of the standard starting dose of gonadotropins, and I find that her response is less than I would have expected, then in a subsequent cycle, things that we will do is either increase the dose of gonadotropins that we give, which works if you don't feel like you've stimulated the entire group of available follicles that are available, or we can change stimulation protocols. And there are a few protocols that we can use. Kind of our standard go-to protocol is the GnRH. It is the GnRH antagonist protocol, and that's the protocol where we stimulate women with follicle stimulating hormone and then prevent them from ovulating early by giving a GnRH antagonist, typically either ganirelix or cetrotide. And that's kind of the go-to protocol, first line protocol that we might use. And then if somebody doesn't respond as well, we might increase the dose of gonadotropins that we give, and sometimes that gets a better response. There are other protocols that we use for women who we consider to be lower responders, and some of these women may have diminished ovarian reserve. In that case, many of these women will also have elevated follicle stimulating hormone levels. If that's the case, we will either use a luteal estrogen protocol. And in the luteal estrogen protocol, we start the estrogen supplementation in the second half of the cycle preceding the actual stimulation cycle. So the late luteal phase of the cycle before you're actually going to be stimulated. And that's designed to bring your follicle stimulating hormone, the follicle stimulating hormone level that you normally produce, down into a normal range so that you don't pre-recruit follicles. And then once you've been on the estrogen for a few days, we would then start to stimulate you with the injectable gonadotropins. The other protocol that we've sometimes used, and it's an older protocol but still very effective in some individuals, is protocol. And in that protocol, instead of using the GnRH antagonist, and a GnRH antagonist again blocks the GnRH receptor to prevent you from having a premature LH surge. In this case, we use a GnRH agonist. And what that does is it downregulates or reduces the number of GnRH receptors so that you can't respond and to any LH surge that might occur. And so those are two methods to try to increase the yield of eggs. It's really difficult sometimes to increase or to improve quality, because quality is very oftentimes tied into just reproductive aging, and so that's not something that we can necessarily change. That being said, there are sometimes, the thought that maybe too high a dose of gonadotropins is not as good for egg quality. And if you find that if you have a diminished ovarian response to high dose gonadotropins, you might actually do just as well with a lower dose of gonadotropins in terms of egg yield, and maybe the quality might be slightly improved. There are also supplements that people are using, and the idea behind many of the supplements is either to improve the hormonal output of estrogen from the ovarian follicles, or improve kind of the metabolic potential of eggs. And I think that when you look at all of these supplements, it's somewhat controversial as to whether they really make a difference. I don't think that any of us believe that they have an adverse effect, so oftentimes we will use them because if there is any potential benefit, we want to take advantage of that. But I don't think that there have been studies that have definitively demonstrated that we can really change the quality of eggs. So other questions. It's nice to see former patients. Hello. Let's see. Patient asked about having had her fallopian tubes tied, but she still wants to have a baby. In most instances, if your ovarian function is fine, in vitro fertilization is the perfect treatment for women who've had fallopian tubes tied, because they should still, if they're the appropriate age, have normal ovarian function. Their partner has normal sperm. We can create embryos that we can transfer directly into the uterus. Another question: does Boston IVF consider transferring mosaic embryos? So let me just describe what a mosaic embryo is. When you do pre-implantation genetic testing, the laboratory is looking to see whether or not the embryo has the appropriate number of chromosomes. Most healthy individuals have 46 chromosomes. Males have 46XY, females 46XX. When we screen embryos, very oftentimes we will, get the result that says that the embryo is normal male or normal female with the normal number of chromosomes. Or we will get information saying that the embryo is abnormal. It has, 20, instead of 46 chromosomes, it has 47, and there's an extra chromosome, let's say 13. But in some instances, you get a result where the embryo is deemed mosaic, meaning that a certain percentage of the cells that have been come back normal karyotype, and then a certain percentage come back an abnormal karyotype. Typically at Boston IVF, we don't request the information regarding mosaicism. We have worked with our laboratory and decided that we either call embryos based on a certain percentage of mosaicism, either normal or abnormal. There are, however, those programs that do identify the level of mosaicism, and then patients have mosaic embryos. And in general, we prefer not to transfer mosaic embryos. We have on occasion transferred mosaic embryos, but typically, we're most comfortable, in terms of kind of drawing the line and just saying this is a normal or an abnormal embryo, as opposed to trying to differentiate which chromosome is mosaic and whether it's safe to transfer or not.